Hello, and thank you everyone for joining CareerCert today for our webinar on pediatric emergencies. I'm your host for the webinar, Danielle. At CareerCert, we are focused on providing emergency healthcare professionals with the training they need to best protect and care for those in their communities. We're so grateful for this opportunity to connect with you today. It's my pleasure to introduce you to our presenter for this webinar, Paul Giannini. Paul started his public safety career in 1983 as a volunteer EMT. He became a volunteer firefighter in 1984 and attended paramedic school in 1985. While in Connecticut, he worked as a career firefighter paramedic, training and quality improvement manager, and was an instructor at multiple EMS programs. He moved to Pennsylvania in 2001, where he started a career in the medical device business while maintaining a second full-time job as a paramedic and volunteering as a firefighter. He held various leadership positions in EMS and was a business development coordinator for the critical care transport program of Lehigh Valley Health Network until 2013. Paul has held various leadership positions in fire and EMS agencies. He currently works as the Director of Clinical Services for Zoll Cardiac Diagnostics in Pittsburgh. He is still active in public safety as a part-time paramedic for Monroeville Fire Company and Penn State EMS. He has been teaching for CareerCert since March 2016. And now, Paul, I will go ahead and let you take it from here.
So, good afternoon. How is everyone today? So I won't be able to hear you guys talk. You'll have to type into the chat room. Just I'm going to ask you a couple of questions about where you live and how long you've been in EMS. All right, Danielle, can you see them typing? There we go. Nice. Let's get one response from Utah. Been in the business for a year. How about the rest of you? Where do you live? What type of system do you work in? And how long have you been in the business? Just kind of like to get to know who I'm talking about since you know about me. All right. So 1984, that's 36 years, right? All right, nice. I actually have a cousin who lives in Wisconsin. He's about on the lake, about halfway between Green Bay and Milwaukee. He was up there about a month ago. All right. So we had a few new folks, a few dinosaurs in the business. That's awesome. One of the things I really enjoy about teaching these programs is that I get to meet people from all over the country and actually, in some cases, all over the world. And it's always interesting to see what other people across the country are doing as far as protocols and some of the things they can do versus that I don't have the ability to do here in Pennsylvania, or some things that are in my protocols that are not in other folks' protocols. So I'm guessing EMS in Alaska has got to be a pretty interesting job. Let's see, we have someone from New York City. The city's so nice they named it twice. Daniel mentioned that I grew up in Connecticut. So I actually grew up in Fairfield County, Connecticut, about an hour outside New York City. And for the 15 years, but the first 15 years I was in Pennsylvania, I was just outside Philadelphia. And for probably 10 of those years when I said the city, I meant New York and not Philly. Excellent. All right. I'll let the rest of you type where you're from and how long you've been in the business. I'll get started so we can kind of stay on track. Let's talk about some pediatric patients today, and we'll talk about some trauma and medical stuff. Talk about some assessment techniques, different. So the person in Pennsylvania, where in Pennsylvania from? Are you in what part of the state are you from? We'll talk about some different respiratory and cardiac issues and trauma scenarios, and then we'll talk about the new 2020 or 2020 AHA guidelines concerning pediatric patients. So I guess the first question I want to ask is how comfortable are you with treating pediatric patients or super sick pediatric patients? I've been in the business a couple of years, and I have to tell you that I love my screaming, crying kids because if you have a pediatric patient who's crying and yelling and carrying on, that means their airway's patent. They've got enough blood pressure to perfuse their brain and their heart and their lungs, and they're generally, at least initially, doing okay. It's the quiet, somnolent ones that kind of scare me a little bit. So, Danielle, do you have a poll that talks about that we can ask, see how comfortable they are with pediatric patients? So, Danielle, do we have any answers yet? All right. See what we have here. Yeah, so we got a few people that nobody's not comfortable also. That's good. A little uncomfortable. Good. 10% of you are very comfortable with pediatric patients. Good for you. I did a shift this past Sunday. I had a 3-week-old, a 25-day-old male with respiratory distress that was brought in by parents to a local community hospital, and they didn't do anything for him. We had to bring him down into the city to UPMC Children's Hospital, and this kid was super sick. And so my level of comfort with pediatric patients is I'm about middle of the road, probably neutral. And I guess the reason for that, from my perspective, is that I don't treat a lot of them. I suspect that many of you have taken either a pediatric advanced life support class or some type of other neonatal resuscitation program. And I've taken several of those myself. And one of the things that I've discovered is when you talk to the nurses and docs that teach those, I've had several nurses that were instructors in those classes saying, yeah, I'll take a sick baby any day. And I'll say, you can have your sick babies. I'll take my sick adults. They're like, yeah, I don't want to touch an adult because it's something they don't deal with on a regular basis. So I think some of our comfort level or discomfort level it revolves around how frequently we treat those patients and how sick they are when we have them. Let's talk about some special considerations for pediatric patients. First of all, when you look at pediatric patients, again, I think we've all heard the phrase multiple times that kids are not little adults, and there are a lot of reasons for that. So vital signs actually are going to change based on age. There was a time several years ago when I was out near Philly where I was the quality improvement officer for the service that I worked for, and I had a conversation with the chief. He had a pediatric patient, the heart rate was 120, and he put 120 in the normal sinus rhythm. So we had a conversation about normal heart rate for the pediatric patient, but you still got to interpret it as sinus tachycardia. And so you see here on the slides, I'm looking at, neonates' heart rates and respiratory rates are going to vary with age as our blood pressure, systolic and diastolic blood pressures. So knowing the normal ranges for those based on your patient's age is going to be pretty important to determine how your patient's reacting to whatever medical or trauma condition they have. And then we have the pediatric assessment triangle, and this is a very quick primary assessment determination of the child's appearance, their work of breathing, and their circulation. And this is like a three-legged stool, so if any one of these legs are broken, the stool is going to fall over. We're going to consider that child sick. Exact numbers really aren't necessary here. We're just kind of going on the overall impression, doing the primary assessment of our patient, and looking from an appearance, work of breathing, and circulation standpoint. Are they stable or not, or are they sick? And then we've got a couple of tools that we can use. The length-based, color-coded pediatric resuscitation tool. There's a pediatric wheel out there. All of those are designed to give us a hand. I like to use the phrase, a short pencil is better than a long memory. So these tools are designed to give us a hand remembering medication dosages, sizes of equipment that we can use to treat these patients. And there are a lot of systems that I know that set up their pediatric equipment based on whatever pediatric resuscitation tool they're using, so that it's easier for us to find. Again, if we're not used to pediatric patients and we have a sick pediatric patient, we're going to be a little anxious potentially, and staying calm in those situations, having all your equipment organized, knowing where to find it, going to give us a little better chance of being successful. So let's look at a couple of anatomical differences between adults and pediatric patients. From an airway and anatomy standpoint, the head is proportionally larger than that of an adult. So when you lay a pediatric patient or an infant supine, their head is normally flexed, which is going to potentially allow their airway to be a little bit more closed off than normal. They have larger tongues. They have little to no neck. Their glottic opening is more anterior. So if you ever end up having to intubate a newborn or a pediatric patient, that intubation is potentially going to be a little more difficult. Their lungs are smaller and their heart's higher in the chest. And particularly with their lungs being smaller, obviously from an anatomic standpoint, when we talk about providing respiratory support or ventilatory support to pediatric patients, it's very important that we use the right sized equipment. I know that you all know that you can take an adult bag and put it on an infant mask, and an infant bag and put it on an adult mask. And obviously those scenarios, neither of those scenarios are going to be beneficial. Certainly putting a neonatal bag valve on an adult mask is not going to give you anywhere near the tidal volume that you need to ventilate an adult. And if you put a pediatric or an adult bag on a neonatal mask when you're trying to ventilate a 1-year-old, you run the risk potentially of causing some barotrauma and putting some air in the patient's stomach, causing them to vomit, those things. So when we talk about intubation of our neonates and pediatric patients, until they're a couple years old, the glottis is a little more floppy. It's longer. It's actually recommended that you use a straight blade when you're intubating a newborn or a 1 or 2 year old, because when you try and get the Macintosh blade in the vallecula, you're not going to get as good visualization. You're not going to be able to move the epiglottis as much out of the way in the airway so that you can get the intubation. So straight blades, Miller blades where you can actually get underneath the epiglottis and lift it out of the way are going to be recommended there. And so cartilage rings in the newborn's trachea and the pediatric patient's trachea are not as developed until they're a couple of years old. And that's what keeps the trachea intact and round. So if you have a very young patient, their trachea is going to be more like a plastic straw, so you can kink it off and obstruct it, whether you hyperflex or hyperextend their neck, so more of a neutral inline position. When you look at the size of the baby's head compared to the rest of their body, a neutral position for them would mean you would have to put something underneath their shoulders to pad their shoulders and get their head and body in line with each other. Again, just laying them on their back, their head's going to be flexed, potentially closing off their airway. And so what is the glottis is not the narrowest part of a pediatric patient's airway. What's the narrowest part of a pediatric patient's airway? Do any or all of you want to type that in the chat room? Well, so the narrowest part of the airway is actually just going to be below the glottis. It's going to be the trachea, right? So which is the reason we used it's subglottic, right? It's the reason we used uncuffed tubes in our newborns and very young pediatric patients, because in adults, the narrowest part of the airway is the glottis, and once you get the endotracheal tube past the glottis, you can inflate the cuff. It'll seal in the trachea, and the tube can move, but doesn't generally move unless you play with it a lot. And so, yeah, the subglottic area, or the top of the trachea, is the narrowest part of a pediatric patient's airway. So let's talk about some cardiac conditions. Ebstein's anomaly. There are many different types of congenital heart defects. They're generally categorized as either cyanotic defects, those that reduce oxygen delivery to the body, and then non-cyanotic defects, those that don't. Ebstein's anomaly is a relatively rare defect where the tricuspid valve isn't formed properly. One common cause of that is fetal exposure to lithium, and that results in tricuspid regurgitation, where blood is pushed back into the right atrium, causing a systolic murmur. About 10% of those patients will also develop Wolff-Parkinson-White syndrome, or WPW. And of all the congenital defects, Ebstein's anomaly has the greatest range of severities. Some babies with this don't survive gestation, and there are others that live a normal life and never need treatment. So when we talk about cyanotic versus non-cyanotic, would Ebstein's anomaly be considered a cyanotic or a non-cyanotic defect? Yeah, it would be considered a cyanotic defect. And these patients that have more severe cases will, in some cases, present themselves just like a patient with right-sided heart failure. They'll have jugular vein distension, edema, because they're kids, you're able to more easily palpate their livers. You get some hepatic venous congestion as well. So a patent ductus arteriosus is a condition where the connection between the pulmonary artery and the aorta remains open. So that connection, when the baby's in utero, allows circulation of blood, of oxygenated blood through from mom to the baby. But that opening normally closes either during or after birth, and that connection that used to be the patent ductus arteriosus becomes the ligamentum arteriosum, that ligament that at the top of the aortic arch that kind of holds the aorta in place. And that defect allows deoxygenated blood or oxygenated blood to flow back into the right side of the heart so that it doesn't make it out to systemic circulation. And so it's relatively common in newborns that have persistent respiratory problems like hypoxia. It has a high occurrence in premature newborns due to the underdevelopment of the heart and lungs. And if the baby also has transposition of great vessels, which we'll talk about shortly, then the ductus arteriosus actually is not surgically closed, since it's the only way that oxygenated blood can mix with the oxygenated blood. And they are given, the babies are given prostaglandins to keep the ductus arteriosus open. And also, you don't want to administer oxygen in these children either, because that will promote the duct to close. So transposition of great vessels is a situation where the right ventricle is attached to the aorta and the left ventricle is attached to the pulmonary artery. So just from an anatomy standpoint, that's not going to be good. And so blood leaving the pulmonary artery or blood leaving the left ventricle goes into the pulmonary artery, goes back to the lungs, and blood coming back from the body gets pumped back out to the body. So there's no connection between the blood coming back to the body going out to the lungs. These patients will also often have a ventricular septal defect, so a hole in the ventricles, and that will allow blood to oxygenated and deoxygenated blood to mix a little bit. If the patient also has a patent ductus arteriosus, so that connection here between the pulmonary artery and the aorta, if that's also open, depending on how patent that is and how much blood gets mixed, this can actually be considered a non-cyanotic defect. But if they don't have a PDA, this is something that's going to require surgery to correct. immediately after the baby's born. So tetralogy of Fallot is a combination of 4 anomalies. It's a combination of a ventricular septal defect, pulmonary stenosis, an overriding aorta, and a right ventricular hypertrophy. And because it's one of the most common forms of congenital heart disease, this is something that if we're doing interfacility transports, we might encounter and probably should be aware of. Infants with tetralogy of Fallot can have hypercyanotic spells. They're actually called TET spells, is what you'll hear them referred to in the hospital. They're characterized by increased cyanosis, irritability, tachycardia, and tachypnea. And sometimes babies who have tetralogy of Fallot will suddenly develop deep blue skin, nails and lips after crying or feeding or when they're agitated. And that can also cause a rapid drop in the amount of oxygen, obviously caused by a rapid drop in the amount of oxygen to the blood. They're most common in young infants around 2 to 4 months old, and toddlers or older children might instinctively squat when they're short of breath. Squatting increases blood flow to the lungs. And remember, giving these patients oxygen will actually cause them to get worse because it'll cause the patent ductus arteriosus to close and worsen the baby's oxygenation. And there is surgery that can be done to correct all of these congenital defects as well. So coarctation of the aorta is a condition where the aorta narrows or constricts just past, if you look at the first 3 branches off the aorta, the first one being the anominate that breaks off into the right subclavian artery and right common carotid artery. The middle branch off the aorta is the left common carotid artery, and then the third branch is the left subclavian artery. And you'll see the narrowing in the aorta just after that. And so this is considered a non-cyanotic defect, but one of the signs that you may see of this is decrease in circulation or cyanosis in the lower extremities. And again, they'll do surgery to dilate the aorta to make it a normal size again so the blood can flow down. The narrowing is after cerebral circulation, so the baby will still have good cerebral circulation and circulation to the upper extremities. It'll just be circulation to the abdomen and lower extremities that is deteriorating because of that narrowing there. It also may cause some left ventricular, elevated left ventricular pressures and cause the baby to have some left ventricular hypertrophy. So another poll question for you. How many of you do 12 leads, or how often do you do 12 leads on your pediatric patients? Okay. So again, a relatively a good mix between those who don't, and then only if they need to by medical command. So I've always thought that. Sorry, I went back one. You know, when we first started doing 12 leads, I thought, yeah, the 3 lead EKG stuff, rhythm interpretation, no problem. And so then we started doing 12 leads back in the, I guess it was probably late 80s or so when I was still working in Connecticut. And I thought, man, I'm never going to get these 12 lead EKGs. It's just they're too complicated. I'll never learn to interpret them. And what I discovered is, what I figured out was that everything we do well, all the skills that you do well, you did poorly until you practiced enough to do it well. And so I started doing 12 leads on all of my patients, and even pediatric patients that didn't have a cardiac and respiratory complaint or didn't need one. I started doing 12 leads on all of my patients, adults and children. So I got some proficiency in interpreting 12 lead EKGs, and now they're much less daunting to me. So it's probably a good idea, certainly, to do 12 leads on your pediatric patients that have a respiratory or a cardiac complaint. And patients that have some type of potential toxin or overdose or some type of substance on board, a lot of those can have cardiotoxic effects as well. So it might be something that you want to consider for your pediatric patients that are overdoses. So I want to talk about commotio cordis for a second. How many of you are familiar with or have done a precordial thump? We got some older folks in the room that have been in the business for a while. And so how many of you have done a precordial thump? Yeah, so as far as the beneficial piece for the congenital defects is with modern medicine, a lot of I don't generally, I see them more in interfacility transports than I do on 911 calls. There with the advances in modern medicine, if mom's getting good prenatal care and getting regular checkups from her physician, a lot of these things are discovered while the baby is still in utero. So in situations where surgery is the correction for the congenital defect, mom knows, the physician and mom are aware of the defect, and the mom's in the hospital and the delivery is planned so that the baby can get surgery right away. So this is, I'm going to knock on wood because I shouldn't put this stuff out in the universe. I have not had a baby on a 911 call that had a congenital defect that needed surgery to be fixed in 37 years. But I have had several of them on both cyanotic and non-cyanotic on critical care transports. Yeah, so the precordial thump, for those of you that aren't familiar, that was a technique that we were taught to do years ago when we saw a patient go into ventricular fibrillation, and it was designed to provide the thought process was anyway, is that it would provide a very low level type of defibrillation to the patient's heart, low level electricity to the patient's heart, to try and defibrillate them basically back into and shut down their electrical system, so a normal pacemaker site would start a normal rhythm while we were getting the defibrillator ready. So commotio cordis is that scenario, except the mechanism for the trauma to the chest is not intentional or by a healthcare provider. So it's a situation where a karate kick, a baseball, a soccer ball, some object hits the chest with just the right amount of force at just the right point in the repolarization phase. So it also has to happen right on if you're familiar with patients that have had an R on T, a PVC, just at the right point in the repolarization phase on the T wave that throws them into ventricular fibrillation. That's what's going on here. So the patient has this blow to the chest that causes this low level energy or electricity to be transmitted to their heart, and it happens to be at just the right point in the repolarization phase that it puts them into cardiac arrest. This is very rare, and in most cases, these children are otherwise healthy. So with rapid defibrillation, if they get defibrillated within the first couple of minutes, they generally do pretty well. It's actually the leading cause of fatalities in youth baseball in the United States, and there are 2 to 3 deaths per year. As far as if you're looking for some statistics on that again, so very, very uncommon. But that 40-pound force to the patient's chest it delivers about a 50 joule energy to the patient's heart. So again, right scenario, right blow, just at the right spot on the chest at the right point in the repolarization phase of the heart can cause the patient to go into cardiac arrest. So when we look at EKGs for our pediatric patients, again, when we're looking at obtaining them, kids that are incredibly tachycardic or bradycardic, we want to kind of get an idea of the rhythm. And anytime you put an EKG, doing an EKG on a patient, it's not a bad idea to do a 12 lead on them. Most of us, including me, need the practice, and they're cheap and they're easy, and it's another EKG to learn how to become more comfortable with interpreting them. Congenital defects, patients that have heart disease, patients that have chest trauma that can cause arrhythmias. And again, I mentioned earlier, any toxic ingestion. I just, kind of a side story about toxic ingestions. I had an interesting one. It was many years ago. I was working on the eastern part of the state, and this is more of an assessment than a cardiac story, but it kind of taught me to change the way I assess kids a little bit. So I was working a 24-hour shift on a Sunday, and my pager went off for a 3-year-old toxic ingestion. And as I'm getting in the ambulance, my cell phone rings, and it's this guy, Dave, the gentleman that I used to go to church with. And he said, I said, listen, Dave, I can't really talk to him. I'm going to an ambulance call. He says, are you going to, and he says his address. I'm like, yeah, actually, that's where I'm being dispatched. So good. I'm glad you're coming. So we get there, and his 3-year-old daughter had taken his mother-in-law, his wife's mother lived with them. And his 3-year-old daughter had taken one of grandma's pills. I don't remember exactly what the medication was. It was a long time ago, but it was a cardiac medication. It was calcium channel blocker, beta blocker of some type. And so he's now all nervous about the fact that his daughter took this pill. And so she's fine, and she's playing, and she's awake and alert, and no problems in playing with her toys. And you know what? Just out of an abundance of caution, let's get her taken to the hospital. I did not do a 12-lead EKG on her, and in hindsight, probably should have, but I didn't do a 12-lead EKG on her. She's awake and alert, stable vital signs, no problem. Get her into the hospital. I say, listen, give me a call, let them know what's going on. I leave. I go back in service. And about 2 hours later, he calls me up, and he's kind of chuckling a little bit. Sweet to hear the story. So they were his daughter's in the emergency department. Nurses and doctors are in there. They're chatting. They're doing the assessment. They're kind of questioning her a little bit. And after about 10 or 15 minutes of them questioning her and kind of her being bewildered about what was going on in the emergency department, she takes this little blue pill out of her pocket. And Dave says, honey, I thought you said you took the pill. She says, I did take the pill, Daddy, but I didn't eat it. So that taught me a lesson when I'm assessing pediatric patients, that they can potentially be very literal. And so I took it, but did you put the pill in your mouth and swallow it is now a question that I would ask if I'm faced with that scenario again. But again, if you have this, she didn't need a 12-lead. In hindsight, had I thought it were a real toxic exposure, I probably should have done one. So when you're doing 12 leads on your pediatric patients, you want to decrease the amount of respiratory artifact. It's helpful to place the leads. Now, as far as when I'm doing 12 leads, they're limb leads. They go on the limbs, somewhere on the patient's arms and legs. I've seen folks place them on the upper and lower abdomen. They really, in my opinion, should be placed on the limbs. But if you place them on the chest, they can be placed on the lower abdomen of your pediatric patients and on the thighs. And again, if you're not doing these on on all of your pediatric patients, you should be doing them on those that have arrhythmias, that have congenital defects, that have some type of potential toxic ingestion or chest trauma. So I suspect you are all trained and have a system that you use to interpret EKGs, whether the rhythm's regular or not, or the rate's normal or not. One of the first things I look for is the rate appropriate for the child's age? And then we're looking at, are there P waves? What's the PR interval? What's the width of the QRS complex? Normal values for those segments and components of the ECG are going to vary a little bit for pediatric patients and for adults. As a general guideline, for pediatric patients, the PR interval should be, instead of 200 milliseconds or less, 160 milliseconds or less. So 4 little boxes or less on your grid, on your 12-lead EKG printout. And the QRS complex should be 80 milliseconds, or 0.08, 2 little squares on the box, or narrower. A PR interval greater than 0.16 or 160 milliseconds is an integrated first-degree block. And again, not necessarily something that you're going to treat, but just something you should identify and wonder what caused it in this pediatric patient. They don't normally have, sorry. I'm moving my mouse that's moving the slides. I apologize for that. They don't normally have, if they've got a normal conduction system, they shouldn't have any issues with conduction defects. So in patients with tachyarrhythmias, it can be helpful to increase the monitor. I don't know if your monitors are capable of increasing the sweep speed. So normally it's 25 millimeters a second. But if you have a patient that's got a severe tachycardia, obviously the faster the tachycardia, the closer all the P waves and QRS complexes are all kind of squeezed together on the page or on the screen. And on your printout, if you have the ability to change the sweep speed or the printout speed to 50 millimeters a second, that will lengthen everything out and allow you to a little more easily identify if there are P waves. What are some of the fastest, we'll talk in a little bit about how the fact that kids compensate much better for hypovolemia than adults do. But what are some of the fastest rates you've seen? I've had people tell me that if it's faster than 160, it can't be sinus, it has to be SVT. And I happen to disagree with that. I've seen tachycardias faster than that, where there was a very clear defined P wave in front of the QRS complex. What are some of the fastest tachycardia rates you've seen on patients that were sinus for you? And if you can remember what the patient's condition was, that'd be interesting as well. Okay, 135. Yeah, I've seen upwards of 200 as well. So I'm guessing that patient was probably a little bit dehydrated or maybe severely dehydrated. What was the scenario where you had a pediatric patient with that heart rate at 210? Oh, okay. Lactate at 22. Okay. So yeah, for that sinus tach at 178, I mean our treatment there is obviously fluid, and more fluid, right? And I don't know how long you had the patient in the field or how long your transport was. Did you have the opportunity to give that patient a decent amount of fluid, and did it have an effect on their heart rate? Did it make them better? So if you're not doing a 12 lead EKG, if you're just doing a rhythm analysis on your patient, I've actually, okay. Um, I've actually found it's easier potentially to get to a patient's extremities than it is to get to their core if I'm not doing a 12 lead. So, but if you have access to the patient, again, remember thermoregulation is going to be a thing specifically not for those of us that live in cooler climates. It's been, kind of in the 30s and 40s here. It snowed a little bit here in the Pittsburgh area a week and a half ago or so. It was gone the next day because it went up above 32. But thermoregulation in kids is going to be an issue. If you're not doing a 12 lead EKG, then you can put those electrodes on the chest. But if you're doing a 12 lead, they should be on the extremities. A leader. How old was that? Just one more question about how old was that pediatric patient that was that sick that needed a liter of fluid? If you got a liter into him and it didn't make a significant difference, I'm guessing that kid was pretty dehydrated, I would suspect, or had some other internal injuries that may have been causing him to bleed. If you said CPAP helped a little, then I'm guessing it would be more neglect than trauma. Oh, sorry. Okay. Got it. All right. Any other questions about the congenital defects? Anything that you want to know that I didn't tell you about the congenital defects or the cardiac stuff that we talked about? Okay. Very good. Then we'll move on. Let's talk a little bit about some trauma scenarios for our pediatric patients. How common are pediatric trauma cases for you folks? I know it's going to vary a little bit depending on the type of system you work in and where you live. But do any of you have a relatively higher than normal volume of pediatric trauma patients. Okay, that's true for me as well. I don't get a lot of pediatric trauma here. So again, one of those things that, depending on the nature of the trauma and how significant the trauma is, what we would consider a high criticality and low frequency skill. So something that we should be, remain familiar with and keep getting some education on. Is trauma is actually the leading cause of death in children from 6 months of age through young adulthood. I've heard that. I worked with somebody out in the eastern part of the state, in Montgomery County, Pennsylvania, who spent the first 5 or 6 years of his career in the St. Louis area, and he said 5 a month. That's actually a higher volume than I would expect. Anyway, again, trauma is the leading cause of death. Wow. That's, yeah, Brooklyn. Okay. Those are tough calls. The most common pediatric injuries related to trauma are a result of motor vehicle accidents, where the pediatric patient's passenger, pedestrian struck, bicycle accidents, submersion injuries or drownings, burns, and firearm injuries, as a couple of folks were talking about in the chat room. So that 12-foot fall is potentially pretty significant when you look at the height of a fall. We talk about 2 to 3 times patient's body height. And so, the possibility is that if you've got a 1 or 2 year old, that the top bunk of a bunk bed, which is, 6.5, 7 feet high, could potentially be a significant fall depending on how young your patient is. And so the systematic approach that we take to assess and manage pediatric trauma, it actually mimics our adult population pretty well. Kids are going to respond a little bit differently to trauma than adults do, but our assessment of trauma patients, whether they're pediatric or adult, is going to be relatively consistent. So there are a couple different resources for us when we're talking about assessing pediatric patients or the severity of injury of pediatric patients. The Glasgow Coma Score has been altered for pediatric patient response. And are all of you familiar with the difference in the pediatric Glasgow Coma Score from the adult Glasgow Coma Score? So the eye opening, right, goes from spontaneous verbal command, pain command to no response, and then the motor responses are relatively similar. It's the verbal responses where we talk about babies that coo and smile appropriately, or cry, or have an appropriate crying or grunt. Okay, yeah, the hospital system where I worked for the flight program is also Lehigh Valley Health and Work in Allentown, PA. Is also they were the regional burn center. They were the local pediatric center. That it was a pretty large facility. They have actually bought several more hospitals since I stopped working there, but they are the Northeast region and Northwest New Jersey regional trauma center, burn center, and pediatric center. So we actually transported, the medevac program transported a lot of pediatric patients into that facility. And so when we look at the Glasgow Coma Score and combine that with the pediatric trauma score, that accounts for the baby's weight, airway status, central nervous system status, systolic blood pressure, any injury patterns or fractures, and wounds. And that can be used to assess, gives us a higher level of kind of a quick overview of how sick or potentially sick a pediatric trauma patient is. Scores of 9 to 12 indicate minor trauma. Scores of 6 to 8 indicate a potentially life-threatening condition, and you want to consider transporting those patients to a trauma center if you have one available to you and close enough to transport either by ground or air. And scores of 0 to 5 indicate a life-threatening condition, and those patients should be transported to a pediatric trauma center if possible. Scores of less than 0, if you look at it, you can get a negative score here. Scores of less than 0 actually indicate conditions that are usually fatal. So when we look at pediatric pedestrian struck, Waddell's triad is a pattern of injury seen in children who are struck by motor vehicles. Now, when you think about it, right, I don't know what type of vehicle you folks drive, but I drive, my daily driver is a Ram pickup. And so, the bumper of that vehicle, a little higher than some passenger cars, and is going to strike an adult somewhere maybe around just above the knees or mid-thigh. Where's the bumper of that pickup truck or any pickup truck going to strike a pediatric patient? Yeah, so certainly in the chest area, potentially head and shoulders, so much higher up on the body, in regions where there are a lot more things that can be damaged and have much more significant resulting trauma. That's generally for most vehicles, right? Kids are shorter, so whether it's a little passenger vehicle or a truck, it's going to hit the pediatric patient higher up in the body. Again, potentially causing them to have more significant trauma to their pelvis, their abdomen, or their chest, or even their head. And the triad, for Waddell's triad, consists of a fractured femoral shaft, interthoracic or interabdominal injuries, and then the collateral head injury. So you've got this patient that gets hit by the car in the thigh, and then hits their abdomen or their chest on the hood of the car. That's going to cause the chest or abdominal injury. And then they get tossed from the car and land on their head, and that's going to cause the head injury. So you have to worry about, again, the challenge with internal trauma is stopping bleeding, right? The bleeding, external bleeding on arms and legs, we can put tourniquets down, we can, if necessary, sterile dressings and bandages to stop the bleeding. We can't stop internal bleeding. So these kids are going to need surgical intervention. Again, why the suggestion of taking them to a trauma center. Are any of you doing critical care transports? And if so, do you see local community hospitals that you serve shipping out their pediatric trauma patients? And are you transporting by ground or air? And just out of curiosity, what are your average transport times? Both, okay. So we talked about 15, 20 minutes actually isn't bad. That's not a bad transport time. When we talked about the third piece of that, Waddell's triad being the head injury, traumatic brain injury is the leading cause of morbidity and mortality in children. It accounts for about 70 to 80% of pediatric deaths from trauma. The death rate for pediatric patients from traumatic brain injury is 5 times higher than that from the next most common cause of pediatric mortality, which is leukemia. And the main source of injury, again, is the motor vehicle crash, where the pediatric patient's the passenger, or a pedestrian struck by a motor vehicle, or a bicyclist, a pediatric bicyclist that's not wearing a helmet. We also see some sports-related traumatic brain injuries, falls, and then obviously you have to kind of consider abuse in there as well, since there are times when abuse is the cause of the pediatric patient's TBI. So injuries to the brain are usually evaluated as primary or secondary injuries. Primary injuries result from penetrating or rapid deceleration or rotational injuries, and they occur at the moment of impact and cause physical and mechanical destruction of the brain tissue. They can include, brain tissue injury itself, diffuse axonal injuries, and cerebral edema. In comparison with primary injuries, many factors may improve or worsen secondary brain injury, which involves a complicated cascade of cellular destruction after the initial injury. The primary injury causes a certain amount of tissue and cellular death. In some injured areas of the brain, there's around the area of the brain that's injured is going to be some tissue that is damaged but not completely injured yet. That's going to be called the penumbra, much like when a patient has a stroke, when they have an embolic stroke or an MI, there's some damaged brain tissue that's hypoxic. There's some damaged cardiac tissue that's hypoxic, and around that dead tissue is tissue that is damaged but not dead yet and still salvageable if you restore circulation soon enough. Same thing here with traumatic brain injuries in pediatric patients. That penumbra is salvageable if the patient receives aggressive treatment quickly enough. So again, aggressive treatment to manage the patient's airway, prevent hypoxia, prevent hypotension, thermoregulation, and anything that we're doing in the field or in the hospital to reduce edema in the brain and reducing intracranial pressure are going to be the things that are going to be beneficial in saving that area of tissue around the damaged part of the brain that can still be salvaged if treatment is aggressive and soon enough. Yeah, so that scenario where the pediatric facility is actually going out and retrieving patients, that's actually pretty common. The hospital in Pittsburgh goes out and gets some of theirs. Children's Hospital of Philadelphia actually has a very aggressive critical care transport team, and so they suggest if you're transporting a pediatric patient or you're referring a pediatric patient to CHOP, that you allow their critical care transport team to come and get the patient. There's a couple reasons for that, and that's number one. That's those pediatric transport teams. That's all they do is pediatric patients. So, whereas those of us that are doing transports that are doing both adult and pediatric patients, the majority of that population being adult patients, we're less familiar with pediatric patients. And the other benefit to having, even from general flight services, whether it's a pediatric specialty or not, the other benefit of having a critical care transport team that goes out and retrieves the patient is, in the situations where I was at Lehigh Valley, when one of our ambulances or flight crews would arrive at whatever community hospital we were retrieving the patient from, care of the patient's transferred. So you're all familiar with the COBRA EMTALA laws that make the sending facility responsible for the patient until they arrive at the receiving facility. Well, if the sending facility is sending their transport team out, my partner and I arrive at the referring facility, and now we've assumed care for the receiving facility, and the hospital that's transporting the patient out is no longer responsible for that patient once we assume patient care. There's a couple of reasons that hospitals they want the business and they want to relieve the sending facility the responsibility of that patient until they get to the receiving facility. And so again, kids with head injuries, right? Managing hypoxia, managing hypotension, thermoregulation, fluid resuscitation, all those are going to help prevent secondary brain injuries. So concussion is the most commonly seen type of traumatic brain injury in pediatric population. And we describe that as an injury to the brain resulting from a force applied directly or indirectly to the head, producing a variety of potential symptoms. And a concussion may or may not initially involve a loss of consciousness. Many of them do, but they don't have to. and that will result in a number of different cognitive, emotional, sleep-related symptoms. And the duration of the symptoms can vary depending on the nature of the blow and the duration and how significant the blow was. They can last from several minutes to several days or weeks or months or longer. And there's a lot of talk, as I suspect you all know, about recurrent concussions and the effects on the brain of recurrent concussions, particularly in adult athletes. It's no different for pediatric patients. And again, because the concussion doesn't have to involve a loss of consciousness, the diagnosis of concussion is generally based on the patient's symptoms. And so when you bring these patients to the hospital, I had a situation a few years ago where my partner and I were working, and his 5-year-old son fell down the stairs. And so we went off duty, met his wife at the hospital. We're talking to the nurse practitioner, the PA that was treating him in the emergency department. So now the conversation comes up of, do we do a CAT scan on, so Logan was awake, falling asleep a little bit, but mostly awake and alert, rousable with verbal stimulus. Seemed to be doing okay. Didn't seem like he had a closed head injury. So the conversation is, do you do a CAT scan, or do you do some type of invasive radiologic exam on this 5-year-old? And the conversation that the PA had with Tom and his wife is, if it were my child, I wouldn't, right? Because of the dose of radiation that's given for a CT scan, pediatric patients are at a higher risk of developing complications from that radiation. So she suggested, and Tom heeded the advice, go home, watch your son, wake him up every couple hours. If he starts having headaches, if he starts having problems with his vision, all the things that you would normally look for, problems with the vision, headache, vomiting, altered level of consciousness, somnolence, bring him back in and we'll do some further testing. And so the lifetime risk of death from cancer resulting from a single CAT scan is 1 in 1,500 for a 1-year-old and 1 in 5,000 for a 10-year-old. So there's actually some significant risk there because of the dose of radiation involved with those studies. So increased intracranial pressure can be caused by many things. Generally, swelling of the brain or bleeding inside the brain cavity in the cranial vault. Remember that if you're bleeding in your arm or your leg, your abdomen, this tissue there can expand, right? You've got bleeding inside your skull. The sutures in your skull don't allow expansion. So when there's only a fixed amount of room inside your skull. And when you start to add more stuff like blood or fluid in there, something has to give, literally. And so it starts putting pressure on the patient's brain. And ultimately, if that pressure gets high enough, it'll start pushing the brain through the big hole at the back of your skull called the foramen magnum, which is, by the time it gets to that situation, those kids are pretty sick. The most common cause of increased intracranial pressure in the pediatric population that's related to trauma is generally a failed cerebrospinal fluid shunt. So what are some common signs and symptoms of a patient that has increased intracranial pressure? I mentioned them a little while ago. Are there any others that you can think of that I didn't mention? We'll talk about Cushing's reflex or Cushing's triad in just a second, because by the time we get to this stage, those patients are pretty sick. Yeah, so initially going to be an altered, just a mild altered, potential altered level of consciousness. Good, dystonia. So one thing that we didn't talk about when we talked about intracranial pressure is anoscoria, or different pupil sizes. And generally, when we talk about unequal pupils, we talk about one being pinpoint, or very constricted, and the other one being very dilated. So you don't normally see patients, 3 millimeters and 4 millimeters. We're not measuring it to that level of specificity, but one pupil pinpoint and one pupil dilated. By the way, anoscoria is a normal finding in about between, depending which reference you read, between 5 and 15% of the population. There are people that just have unequal pupils by normal. So if that's the only abnormal neurologic finding in your patient, by the time your patient has unequal pupils, they've got significant intracranial pressure. You'll have some of the other signs. You'll have altered level of consciousness. You'll have patient falling asleep, patient vomiting, maybe complaining of headache if they can do that, if they're conscious enough to do that. And you may even have some of the signs of Cushing's triad. So unequal pupil sizes. There's one more that I'm actually thinking of that I didn't mention before, that we may see in patients that have a significantly advanced head injury that causes a lot of intracranial pressure. Anybody? No takers? So vomiting's in there. I was thinking actually something more severe than that. I was thinking of posturing, decorticate and decerebrate posturing. So again, by the time your patient has unequal pupils, good vertigo and loss of balance can generally potentially be an earlier sign. So let's talk about Cushing's triad for just a second. The three things that are caused by significant intracranial pressure: hypertension, bradycardia, and altered respiratory pattern. And so that pattern kind of comes about because your body has, you start to bleed into your brain, and your intracranial pressure starts to go up, and your body says, oh, wait a minute, I have to increase my systolic blood pressure because your mean arterial pressure has to be higher than your intracranial pressure, or you're not going to have any cerebral perfusion pressure. Say that 3 times fast. So the pressure in your arteries that's pushing blood into your carotid arteries into your brain has to be higher than the pressure in your brain wanting to keep fluid out. And so you increase your systolic blood pressure a little bit. And then your body, as you develop more increased intracranial pressure and your systolic blood pressure gets higher, the barrier to say, wait a minute, my blood pressure is too high. I need to lower the rate of the pump so I can drop my blood pressure a little bit. Meanwhile, your peripheral vasculature is squeezing down so you can keep your blood pressure high so that you can have a mean arterial pressure higher than your intracranial pressure so that you're actually perfusing blood into your brain. And at some point, the intracranial pressure gets high enough that it starts to push on the respiratory center in your pons or medulla and cause the altered respiratory patterns. That's kind of the physiology behind Cushing's triad. So when we look at significance or severity of head injuries, we've got epidural hematomas, we've got subdural hematomas, we've got intracerebral bleeds. Epidural hematomas are generally an arterial bleed caused by a laceration of the middle meningeal artery in most cases. And so that blood vessel is located outside the dura, between the skull and the dura mater. And so it can get torn actually relatively easily with a blow to the head, either a blunt or penetrating blow to the head or a skull fracture could lacerate that artery. And what's the classic? There's a classic pattern of presentation for patients that have epidural bleeds. Can any or all of you tell me what that is? Yeah, so the patient has an initial loss of consciousness from the blow to the head, the concussion, if you will. They have a loss of consciousness, and they have a lucid interval. They have a return to awake and alert and talking to you, and then very shortly after that, a rapid declining loss of consciousness to the point where they're unresponsive. And that's because the patient's has got an arterial bleed. So the initial loss of consciousness is from the concussion. Then they're awake and alert, and that bleeding is rapid because of the arterial bleeding from the epidural hematoma, and they'll lose consciousness and degrade their level of consciousness pretty quickly, as opposed to a subdural hematoma, which is a venous bleed, and the classic pattern we see there is a fall or some type of head trauma hours or days ago. Right, we look at folks that have chronic alcohol problems and older folks that fall down a lot and bump their heads, and their venous bleeds, and so that increase in intracranial pressure takes a much longer period of time, hours or days, from the time of the trauma to the time the patient's having significant neurologic symptoms. So less than 4% of pediatric patients have an injury to the spine and or spinal cord. Mortality rate related to spinal cord injuries in children is more than double that of the adult population. And serious neurologic injuries are more common in older children and are often associated with sports injuries, diving injuries, or falls. The incidence of spinal cord injury dramatically increases in adolescents between 15 and 18 years of age, probably because they're feeling a little more invincible. And again, many of those are sports-related injuries. Of all sports-related injuries and reported spinal cord injuries, 30 to 50% involve the cervical spine and result in quadriplegia and or some type of severe or significant disability. Injuries in children younger than 8 years are most commonly found at the C1 level, C1 to C3 level, whereas older children and adults tend to have injuries to the lower cervical spine. And because of the anatomy of the spine or the anatomic differences between children and adults, children are more prone to sustaining cervical spine injuries of greater severity. And by comparison, older children and adults incur injuries that are more evenly distributed throughout the cervical and the thoracic spine. So there's a term called SCIWORA. It stands for spinal cord injury without radiographic abnormalities. And because children generally have weaker spinal ligaments and increased mobility of their spine, they may sustain spinal cord damage and ligament damage without damage to the vertebrae themselves, without trauma to the vertebrae. And that's what that's called. That condition is often associated with a poor neurologic outcome. A high portion of complete neurologic injuries, those where there's no sensory or motor function below the level of the injury, and a high susceptibility to delayed neurologic deficit. If a child reports pain, has difficulty with range of motion, or is unresponsive, those are the kids that we should perform, spinal cord immobilization or spinal immobilization on. Spinal cord injury before the age of 15 is actually relatively rare, but it can have important physiologic and psychologic consequences. Although the exact frequency is unknown, it represents about 4% or a little less than 4% of overall incidence of spinal cord injury nationally. So we talked earlier about the differences in the anatomy of the pediatric airway and the adult airway. And when you look at trauma and facial injuries, you'll look at soft tissue swelling. Kids' airways are a little bit smaller, right? So they've got less. It takes a little less edema to close off their airways or restrict their airways. Again, your head injuries can cause a decrease in consciousness, and the number one cause of an airway of obstruction in an unconscious patient is the tongue, so you have to worry about that potential obstruction as well. So tension pneumothoraces, what are a couple of signs and symptoms that we normally see of a patient with a tension pneumothorax? Yeah, so either decreased or absent breath sounds on one side. Again, there's going to be some type of index of suspicion based on the blunt trauma that the patient received, generally caused by some type of trauma to the chest where a rib's broken and it punctures the lung. And over a period of time, the pneumothorax develops. If you're looking at a pediatric patient, 14 or 16 gauge midclavicular line, second intercostal space above the top of the third rib. For infants, you're looking at 22 or 23 gauge butterfly needles. And there you're just leaving the needle in place. There's no catheter for that. And then, the goal there obviously is to, is anybody doing chest decompressions at the fifth intercostal space, mid-axillary line or interior axillary line? Yeah, so tracheal deviation is going to be a late finding, and everyone talks about tracheal deviation, and that's something generally that you'll have to feel and not see. It's kind of tougher to see. Maybe in a pediatric patient that's very, very thin. I've met a couple of folks in teaching these classes that are actually doing their chest decompressions, either interior axillary or mid-axillary line, fifth intercostal space with a needle, which is where they put the chest tube in the hospital. And so a hemothorax, by contrast, is blood in the chest as opposed to air in the chest. One of my favorite words in EMT school, because I was young and thought it was kind of cool, and can really see hemopneumothorax was I thought was a fun word 35 years ago. Not so fun for the patient, just kind of fun to say. And so instead of with a pneumothorax we have air in the chest, in hemothorax we have blood in the chest, and really there's not a lot. I don't know any pre-hospital systems, at least in the 911 setting, that are putting chest tubes in the field. If you are, please let me know. I want to come work there. But what again, the chest tube is going in fifth intercostal space, either interior or mid-axillary line. And then they're going to attach that chest tube to some type of vacuum, a pleurovac, or some type of suction device that's going to remove the blood from the patient's chest cavity. Again, the goal with hemothorax and pneumothoraces is obviously to remove the substance that's in the chest cavity that's causing the lung to collapse so that the lung can re-expand. And remember, if you've got a patient that's got a hemothorax, they're bleeding somewhere, you want to make sure that you've got some IV access, and that you're giving them a little bit of fluid. Can't really overload them with fluid. We're not tanking them up again until a surgeon gets in and closes off whatever is bleeding. But we should at least have access so they can do that when they get them to the hospital. So what the pediatric rule of nines is, are you all familiar with the pediatric rule of nines versus the adult rule of nines? It's going to change a little bit. And again, there's a survey there for you to look at or to take. Yeah, so again, it's going to vary a little bit depending on the age of the patient. And there are references for 1 to 4-year-old, 5 to 9-year-old, and 10 to 14 years old. Each body part's going to have a different value, whereas they're all broken up into 9 for adult patients. Going to be a little bit different for our pediatric patients. And again, instead of memorizing these, I choose to have a reference in my pocket in my phone that says if I ever need to do a rule of nines on a pediatric patient, I've got something that based on the patient's age. Yeah, again, you're going to get the head's worth 18, arms are worth 9.5, legs are worth 14 each, and then chest and front and back 18 each. All right. A couple of quick slides on the 2020 AHA guidelines and algorithms. Any questions so far on any of the trauma topics that we've discussed? So you do, so that there is somebody out there that's doing your pneumothorax, what's the phrase I'm looking for? Decompressions. Escape me for a second, sorry. You're decompressions for pneumothorax at the fifth intercostal space. Have you seen that work? Have you had to know anyone in your service, or have you had to do one? Has that been effective? I've only done them anteriorly. I've never done one laterally. So we'll move on while we wait for that person to respond and kind of come back to it if they type an answer or when they type an answer. There we go. Yeah, I would think, okay, so for your pediatric patients on the right-hand side, I would think that probably makes sense to me. Yep. I guess that would be pretty bad if you, yeah, then the liver would not be good patient care. But again, another skill, right? The more you practice it, the better you are at it. So you look at the causes of pediatric cardiac arrest in infants. Remember that pediatric and infant cardiac arrests are not generally cardiac in nature; they're more respiratory in nature. And the goal for our patients, the general progression is some type of respiratory distress to respiratory failure to respiratory arrest to cardiac arrest. So if we can intervene in those situations where and aggressive airway management and ventilation and airway support to that patient, the goal obviously for our infant and young pediatric patients is to prevent the cardiac arrest by fixing the respiratory problem. And then in a situation where the patient goes into cardiac arrest, there's has been a lot of talk now for the past certainly 10, 15 years, if not longer, about community CPR, and the Heart Association is doing hands-only CPR programs for the lay public now, because there are people that are afraid to, not just because of coronavirus, but even in the last 10 years or so, people are afraid to put their mouth on someone, blow in the mouth of someone that they don't know. So compressions are better than nothing. And again, increasing the number of people that know how to do CPR. I know that the Seattle-Tacoma area in Washington State has had a robust public CPR education program for many years now. So I've actually never been to Seattle, but from what I'm told, if you go into cardiac arrest in Seattle, the chances of someone near you or around you knowing how to do CPR and starting it is actually pretty good. So we talk about the components of high quality CPR. We talk about chest compressions at a rate between 100 and 120. Yep, and a lot of folks are teaching hands-only CPR now as well. Again, just because it will allow the general public to do something as opposed to not doing anything, and still provide some benefit to the patient. Remember, we inhale roughly 20.5, 26%, 20.6% oxygen. We exhale, 19%. So there's some oxygen left in our body once it passes the lungs once, and we can circulate that oxygen, that blood a few times, and still have oxygen in it to go into the tissues. Talk about a rate of 100 to 120, and we cap it at 120 because anything faster than that causes a decrease in the diastolic phase and less ventricular filling. Compressions at 1.5 inches to 2 inches, complete recoil of the chest and minimal interruptions, and avoiding excessive ventilation. And so again, the excessive ventilation piece is a big deal as well, right? We're using the right size bag, we're maintaining good airway management, and we're increasing ventilation. We're infusing the ventilation or ventilating the patient just so we get some chest rise, and then stopping. We don't want to overinflate the lungs for two reasons. We don't put air in the stomach, don't want to cause barotrauma. And so there are studies that have found that the effectiveness of the two thumb, with what the Heart Association taught a few years ago, the two thumb hands encircling the chest technique is not something that's beneficial in the pre-hospital setting. So, we're not doing CPR in the neonatal and delivery room, right? This is for bigger kids, and our hands may not be able to get around them. So they're recommending for us now 2 fingers, middle of the chest, at the nipple line and the lower half of the sternum. All right. What questions do you have that I can answer for you, or what do you want to know that I haven't told you? We have a scenario for you. We have a few minutes. Yeah, we do have a few minutes left. Great. Okay, Danielle, you want to take control and there we go. Move a couple of things around on my screen here, folks. All right, so you and your partner Vincent have just finished lunch and you're relaxing in the truck bay. It's a hot summer afternoon. Go to the next slide. And so he's been a medic for 10 years. You've worked as many calls with medicals over the last couple of years. And he's looking forward to a vacation. Now, a vacation in this day and age obviously is more of a staycation, because if you're going anywhere that's outside, in many cases outside your state, you're gonna have to sit tight for a couple of weeks when you get home. But he's looking forward to a week off. And they're gonna plan on traveling to the ocean, right? He doesn't worry about the quarantine period on the way back. All of a sudden, here comes the dispatch. He responded to Dillon Road eastbound just past Pinebird Drive for a 2-vehicle crash. So you acknowledge the dispatch, and you head on down the road. And next slide. And so the communication center comes back and says multiple calls reporting major damage to both vehicles. Kind of gets your mind in the scenario of, okay, this is a relatively high-speed road. It sounds like with significant damage. You got 10 people picking up their cell phones and calling 911. And fire rescue gets there before you do. They have 3 patients, 2 adults, and one's a critical pediatric patient. So the first thing you want to do when you get that information, probably call some additional resources, get a couple more ambulances on the road. Yeah, so I think many of us are thinking that, man, there's the sick kid thing again, not my favorite. All right, so you make your way to the scene, and this is what you see. Traffic's controlled by fire department, which is always a wonderful thing. 2 vehicles, extensive front end damage and airbag deployment. And so you put on your PPE, you approach the scene, and the pediatric patient was not restrained. It looks like he was tossed around the inside of the vehicle when they crashed. The 3-year-old is unresponsive and currently being attended to by Tommy. He's a rescue tech who's also a paramedic on the fire department. So you got at least 3 providers now. And you still haven't checked the 2 drivers yet. All right, so what do you want to do first? Where are we putting our efforts? Okay, so we're going to check the 2 drivers. Okay, so you go to the 2 remaining patients, and this is what you see. They've only sustained minor injuries, and they're refusing EMS assistance in transport. All right, good job. Okay, so now we still have our critical pediatric patient that we have to attend to, right? Nope. Where do you go next? Okay, any other questions, Danielle?
Doesn't look like there are any other ones coming through.
Okay.
So thank you so much, Paul, for helping us out today and for
No, my pleasure. Nice to meet you all. Until we see each other again, please be safe and take care of yourselves.
Yes, and thank you everyone for joining us today. Visit us at careercert.com for more webinars and free resources. If you would like to earn CAPC accredited CE hours again for attending this webinar, please complete the assessment. We will distribute to you, and that should come to your inbox within 48 hours after this webinar is finished. And once you complete that assessment, we'll go ahead and get those CE hours to you. Thank you again for connecting with us today, and thank you for your sacrifice to make our communities safer places. Stay safe and take care. Happy holidays, everyone.